and bioethicists Brian Kane and MC Sullivan. Before we get started, I'd like to mention that today's session is being recorded and you are currently in a listen-only mode. A large portion of today's webinar will be a question and answer period, so please use the questions panel on the right side of your screen to begin submitting questions at any time for our panelists to discuss. We also encourage you to share what you are doing to support healthcare staff during this stressful time, as well as links to resources that you have found helpful. We will share them after the session on the SCC website's COVID-19 resource page. If you experience any technical difficulties during today's webinar, you can click the Help tab at the top of your control panel or ask me a question directly in the questions panel. Now, without further delay, it is my pleasure to introduce your moderator for today, Denise Hess, the Executive Director of the Supportive Care Coalition.
Thank you so much, Brianne, and welcome everyone to today's webinar. We are so grateful that you have taken the time to join us and join our panelists. As we begin today especially, I have been reminded of the very unique narrative within the Hebrew Scriptures. Unique because it's one of the two books in the Hebrew Scriptures that never mentions God directly. And the book I'm thinking of is tells the story of a young Hebrew woman named Esther. And as the narrative goes, she finds herself to be the new wife of the king of Persia. And she finds herself to be the new wife, unknown to the king, a Hebrew woman, at the exact time that the king has an advisor who has decided to persuade the king that it is a good idea to exterminate all of the Hebrews in his kingdom. So Esther finds herself in a very terrible position. Today, we might say she finds herself in a position of moral distress. Because on the one hand, if she reveals to her king that she is a Hebrew woman, she could be killed. On the other hand, if she doesn't intercede with the king, her people could be killed. So in this dilemma, she seeks the advice of her uncle Mordecai. And he, in beautiful words, challenges her to live into the fullest expression of her calling. And he says that to her in words that have become well known from this book in the Hebrew Scriptures. He says to her, you know, Esther, maybe you find yourself in this very position for exactly such a time as this. So for all of you joining us today, I would like to remind myself and our panelists and all of us that maybe those words of Mordecai to Esther are also for us. And may we, like Esther, in these very trying and difficult and stressful and unprecedented times, live into the fullest expression of our calling for such a time as this. And may we, like Esther, know that we are not alone in such a time as this. And may we, like Esther, know that we are always enfolded in the mercy of the Holy One, where God is named and in the places where God is not named. And so with that, I do welcome all of you. For those of you learning about the Supportive Care Coalition for the first time, we are a partnership of Catholic healthcare ministries from across the United States dedicated to advancing excellence in palliative care. We do that through the sharing of resources, through educational events like this, through the development of materials related to the integration of ethics in palliative care practice, and through the promotion of spirituality as an essential element of palliative care practice. And coalition members have access to our regular monthly webinars and numerous resources on our website, and a community of like-minded learners from all disciplines. And as we begin, as Brianne mentioned, we do just want to show you our COVID COVID-19 resource page. If you navigate to our website, supportivecarecoalition.org, you will see that we are updating really on a daily basis the resources that you can find there. Specifically today in your handouts tab on the dashboard, we have included 2 of the newer resources from our COVID-19 resource page. One, a document that the Supportive Care Coalition and the Catholic Health Association developed together, and that's guidance on code status for COVID-19 positive patients. And a second document that has been released by the Catholic Health Association that discusses resource allocation and the Catholic perspectives on that during crisis situations such as we find ourselves in. In addition, we have not forgotten about our caregivers and their well-being, and that is of supreme importance to us. So we also have a caregiver well-being page. And on that page, again, on a daily basis, we are adding new short reflections, new short readings, short meditations, designed for caregivers in whatever setting they find themselves to click, take a pause, use the resource, and then resume your work in whatever form it is. And specifically, we want to highlight the Catholic Health Association's recent release. The first 3 resources you see on the page there, the Pause, Breathe, and Heal series from the Catholic Health Association, is actually a short 10 video series of just moments to click and pause and take a moment to pray and reflect and breathe. And so we highly recommend those resources to you all. Today, for those of you who were with us last Thursday, we are really excited to welcome back 4 panelists to lead us in our discussion. We have Dr. Muyiwa Adeboye, the Medical Director of Palliative Care at Ascension Health, Dr. Greg Vandekeith, the Medical Director of Palliative Care Practice Group at Providence St. Joseph Health. We have Brian Kane, the Senior Director of Ethics at the Catholic Health Association, and MC Sullivan, the Chief Healthcare Ethicist and Director of the Initiative on Palliative Care and Advanced Care Planning at the Archdiocese of Boston. Our plan for our hour together today with them is to have our panelists begin by addressing some of the common questions that were brought up during last week's webinar. That recording is available for you to listen to on our website. And then, as time allows, address some of the questions that you all will be entering in the questions panel as our discussion continues. So we encourage you to start doing that as the questions come to the surface. We'll hopefully have some time at the end to get to those questions. The questions that we don't get to today, this webinar is ending up being part of a 5-webinar series. So we will be back again with this panel on April 16th, and we will continue to address the questions that come up today and the ones that come up between now and April 16th. And so without further delay, I will turn it over to our panelists, and we will begin with question 1 here on moral distress. So this is from one of our audience members. They say, I am experiencing distress. On the one hand, I feel a duty to be on the units, caring for patients, but on the other hand, I'm worried about my own personal safety. Also, I have never provided palliative care in such a depersonalizing way, either by phone or through PPE gear. This was not how I was trained. Help. So, Drs. Vandekeith and Adeboye, will you kick us off by addressing this question?
Thank you, Denise. And I think it's very fitting that the question of moral distress lead today's session. Working in our hospital and to a lesser extent in our outpatient clinic, I've been hearing a lot of expressions of moral distress. The one that comes up first in here is the question of safety, intention against the duty to serve, and that we've all taken various professional commitments, perhaps even oaths, that we will be of service to patients in a time of serious need. And the COVID-19 pandemic is indeed a time of serious need. And so, like the story of Esther that you opened with, we are being faced with, perhaps we are in this time exactly when service is the most required, and yet what is the personal risk and cost of that service? I think of an article that was in the New York Times recently, written by a hospitalist from the Evergreen Health System in suburban Seattle, who was caring for some of the very earliest COVID positive patients in the United States. In the article, he talks about saying goodbye to his wife and two young sons and realizing that he could never see them again. One of his own critical care colleagues or emergency department colleagues ended up in the ICU on a ventilator with COVID-related illness. And so he refers to saying, I love you every time instead of goodbye, and concludes with looking towards when I love you becomes an expression of hello rather than goodbye. But a beautifully rendered tale of the internal tension one feels to feel that calling to service, but recognizing one is at risk themselves. Second layer in this question is a part about protective or personal protective equipment. Before the whole COVID thing really blew up, I had to go into an ICU room to have a very complex and nuanced conversation with a woman who just had a stroke. And I was required to wear, because she was a person under investigation, I was required to wear the type of protective gear where it's the hood with the clear mask and the machine that blows air so that I don't inhale the virus. So I'm in a device that I'm really having trouble even just talking to the nurse outside the room. Go into the room, and the patient's wearing a BiPAP mask. She doesn't have her dentures in, and English is not her first language, and she's had a stroke. You can imagine the communication challenges in a situation like this that are exacerbated by the protective gear that's being required. Add another layer. She's only allowed 0 visitors while she's under investigation, although this actually happened before the visitation policies were as strict as they are now. And I think that's an area of moral distress that actually didn't make its way into this slide, but is one of the ones I'm hearing the most commonly. That is, most of our patients are not being allowed any visitors. Those who are actively dying might be allowed 1 visitor when they reach their final hours of life. I had a daughter on the phone last Sunday, very distressed because her mother had been transitioned to comfort measures only, was anticipated to die within a matter of days to a week or two, but she wasn't within hours of death, so no family was being allowed in to be with their mother. We're witnessing the suffering and the distress that this is causing the family members, and being exposed to that suffering and that distress creates suffering and distress within us as caregivers, because we want to honor 2 goods: the good of this family, and in the words of the daughter, I want to have all 7 of her kids around her showering her with love at this most tender moment in her life, versus the good of public health, which is, but we can't allow that, or we risk exposing people to this virus and actually working against all of the public health measures we've been undertaking. And the staff recognize I can't honor both goods, and it causes internal distress. And we shared briefly on the last phone call about the concept of moral residue. Each event like this, you don't fully reset to baseline, and so the cumulative moral distress actually becomes greater than it might be if taken in individual events. We did scramble. We were able to get that patient discharged home on a weekend. They were going to go a day without hospice care just to get her home. But we did it. And again, here I hold up our nurses and social workers who really did the heavy lifting to make this discharge happen, to get things set up at home so they could manage for 24 hours without hospice care, but doing it for that family. And the sense of purpose and calling that the staff involved in that case felt, saying we did the right thing, we did a good thing, to help offset some of that distress. So with that, I'll toss to you, Moyowa, and ask you to comment on this question as well.
Thank you, Greg. Thank you for sharing that. I think it resonates with a lot of people and myself personally. I think one of the things that we're learning from all of this is things are evolving constantly. There's new things coming out probably every day, if not even every hour. There is the duty to care for patients, but there's also the duty to be safe. And I think as palliative care physicians, it's difficult. I found myself in that situation recently. We had a person under investigation who was in a room. You could tell he was scared. And we have the duty also to be good stewards of whatever resources we have in the situations we find ourselves right now, because these resources are scarce, either the PPE or even ourselves, which means we have to work in different ways. So being mindful of that, I think is helpful. I think the other thing also is realizing that we're not alone. We're part of a team, and hopefully working with your teams and relying on your teams for support is also something that I think is helpful. There are a few things I've learned that I think have been helpful through this. One, being mindful that this is a different environment we're working with, and making the patients aware of that and acknowledging their own anxieties around this. And I think making them aware that also we feel the same way makes them know that there's a connection there on a personal level. I think knowing that there's not going to be enough PPE, we have to kind of be creative and innovative in terms of how we can make workarounds to make it less anxiety provoking. In the scenario we found ourselves when we got to the room, we normally work as a team. So myself and the social worker got to this room and found out that he was a person under investigation. Talked to the nursing staff at bedside. One of the things that we found helpful was each room has a telephone that's in there with the patient, and the patient also had their cell phone numbers. You can get the cell phone numbers from the medical records, but the nursing staff had also put the phone number for the room on the window facing the patient, and there was a phone right out there, so you could call. And I did that, called the patient and waved, told him I'm right here, acknowledged that he was scared, acknowledged that this was not a unique situation, a normal situation for either one of us. And I think that was helpful. Got to listen and then just go into the normal routine of what we do normally. Unfortunately, this is not normal. Acknowledge that, ask for permission to speak to family, call family, and called him back. That alone, I think, was helpful to kind of make the distress or the difficulty that was felt initially more tolerable, if I should put it in a way like that, but it was still difficult. This is not how we're practicing, but we have to acknowledge that for ourselves and for the patients we're caring for. And I think also realizing that we're not working alone and part of a team.
Wonderful. I would invite Brian and MC to continue and on this question one.
Thanks, Denise. I am struck by several things. Certainly the question and the fact that it is at this point in time almost universally expressed throughout our country. Secondly, I'm very struck by the beautiful elaboration on both the issues and the responses that they're thinking about and actually implementing by Muyiwa and Greg. There are a few things that I'm thinking about as I listen, and in fact, cue to everybody outside of the screen here, we actually saw these questions before, so some of us have been thinking about them for a few days. Timing is everything, right? And so part of what I'm going to say is really for next time, or it's for the people who are not yet in the thick of things. And there is a lot of our country that not yet has seen the kind of volume and the severity of illness that some parts of our country have seen. So as one of my colleagues in a protocol triage protocol meeting the other day said, there's no time for touchy-feely and supporting each other. But as Muyiwa just said, there has to be, this notion that most of these decisions, the protocols that we're seeing, rest on multiple shoulders is already, a little bit of help. But the thing that I'm struck by is that both of the situations defined in this question are not so much a question of moral distress, but of morale distress. So moral distress, not to get too into the weeds and academic, because the situation is so real that it's almost offensive to be too academic at this point. But moral distress is when you're actually faced with a choice that's wrong. It strikes you in every part of your being that it's wrong, not that it's not ideal. So what we're talking about in each of the instances in question one are things that we're being asked not to meet the standards that we hold for ourselves, that we hold for our profession, that we have tried to teach others and live ourselves. So part of what I would love to say, and that we have to communicate, those of you who are leaders of these teams, those of you who have the moments of a break time in a lounge or sitting over coffee, we have to let each other up a little bit. We cannot, per se, almost in a pandemic situation, adhere to the highest standard, because that would be all about this individual and how they relate and live up to their duties to this other individual. That's how we can be aspirational, idealistic, and be our best selves. The moment that there are competing and in some cases conflicting claims on our duty, we have to back off and find out something that's more about the common good. And that's what we see in the first part of this story. These folks are frontliners, and they're everybody from the grocery workers and the first responders to our healthcare workers in various healthcare settings are having to figure out and live with and need to let themselves off the hook for admitting that they're human, and they have competing claims on their duty, their professional duty and their personal, familial, communal duties. That's true in the second issue in this question as well, where our typical way, particularly in palliative care, of dealing with patients is to touch them, to stare into their eyes, to have all the time in the world, we hope, compared to the 11 minutes that might happen in a clinic, to talk about important issues, to frame them, to contextualize them. There's no time for that. There's no time, and the reality is that it's not a question of, do I want to do it this way or will I do it that way? There is one prescribed way to do it. For those folks who are not yet into the thick of things and are still massaging their triage protocols, their scarce resource allocation protocols, I would exhort you in creating these documents that are going to be disseminated to your staff, because there is not time to do in-services and medical grand rounds and nursing rounds on them. But I would exhort you to put into the beginning of these protocols some language about the traditional ethical values, and we're going to talk about them with some of the other questions, and principles that have informed this kind of decision making before. And the reason to do that is not to be all academic and, oh gosh, look at people have written papers about this and there have been instances of this before, but it's to reassure our staff and our colleagues that they're facing something that has been faced before. This kind of situation is not a fly by the seat of your pants situation. There has been thoughtful and meaningful and substantive discussion and contemplation. The answers are not always satisfactory, but they are not also kind of serendipitous and fortuitous and all in the moment. And I think there's some reassurance there. And I think the moral distress and actually the moral fatigue and the, quite frankly, post-traumatic stress that we're going to see among our healthcare colleagues, our first responder colleagues, and our grocery clerks might be assuaged down the road somewhat by knowing that this isn't something that was just decided in the moment, that the protocols, the strategies, the scoring systems that all get implemented into these very difficult decisions are thoughtfully contemplated and have been used in other situations before. Thanks, Ryan.
Yes, I completely agree with everything you just said, MC. And I think it's important to emphasize again, we're looking at trying to do the best we can by our patients, but we also need to, as a community, as a healthcare community, really, really pay attention as well to the needs of all of our frontline people. This is going to be a very difficult time, and while it can't be the primary thing we're worrying about, because we really just want to keep people alive and treat them as best we can, it certainly is going to be a major factor in terms of caring for our community. I mean, when I worked on an ICU the ICU head nurse had something that she called twice a month resiliency rounds, where it just a moment to pause to say, what are we struggling with? How can we resolve some of these things? And again, as we all know in clinical settings, some problems are not resolvable, but it's important to acknowledge that as well, that sometimes you can't solve the problems that you're facing, but you can try to do the best you can in what are very, very trying circumstances. So, I think that your distinction between moral and morale is a really, really good one to keep in mind.
Great. Thank you both. So moving on to question 2, we will continue on this theme of some of the issues that clinicians are facing around workforce challenges. So this question, I think we can envision it coming from any member of the palliative care interdisciplinary team. And they are saying, I am the solo palliative care clinician in my setting. And there's talk that I am going to be asked, or I already have been asked, to redeploy to my primary specialty if needed. And this will limit the availability of specialty palliative care services. What should I do? Greg and Louis?
Thanks, Denise. I think I'm going first with this one. This is not an unusual scenario. This highlights the scarcity of palliative care providers across the country, across the world. And indeed, we're a scarce resource at this time. And I think one of the points that this person actually points out is indirectly the layering of categories of palliative care, having the primary palliative care and the specialty palliative care needs. I'm not sure what this person's primary specialty is, but I think historically we know that palliative care providers come from a variety of sources, backgrounds, internal medicine, family medicine, we have OBGYN, we have psychiatry, we have surgery. And so probably this person is being asked now to man one of those primary specialties they probably trained in. This is not uncommon. I'm hearing that more and more. And so kind of acknowledging that. But I think I will bring us all to various articles that have been coming out of late. And I think there was one recently that was shared with us just this morning, about from the Wall Street Journal this morning. I think it was Stephanie Amore, just talking about the need for palliative care at a time like this, specialty level palliative care. The Center to Advance Palliative Care has been doing a lot to highlight this. And I think one of the key things that came out in a webinar 2 weeks ago with Diane Meyer and Sean Morrison was having a seat at the table for what we would call the incident commands at our various locales, and having a voice, because sometimes what we find, and it's not intentional, is we palliative care providers tend to kind of be in our shells in different places. And so we're not at the forefront or at the forethought of a lot of issues. Right now, there's a light being shined on most of us. And in as much as we do not want to burn out all the scarce resources we have, it calls on us to be a bit efficient and effective in how we're doing things. And so having a seat at the table and making people aware of the gifts you can bring to the table at this time. One of the things that came up in the article was the palliative care teams are asking as supports or coaches to the frontline staff, helping train them in communication skills, manning call centers, being available over the phone for symptom management and things like that. I think that's something we can look at here. And also there's been the thought about looking at where things are at and categorizing things. As has been mentioned, some places are not in the crisis mode yet, and kind of work is going on as is. I'm hearing a lot about places not being as busy as they usually have been, and I think that's the reality for some places. But I think in anticipation of what could be the crisis down the line is again going back to the point of having a seat at that table to say, what, this is what we can offer, this is what we can do, pulling resources from CAPC, Spiritual Care Coalition, in terms of what other places are doing, to share that with your leadership and say, here's what's being done. How can we work on this locally, knowing where you find yourselves and the culture of what that place is? I'll hand it over to you, Greg.
Thank you, Moyo. As I look at this, a couple of other things come to mind as well. I really appreciate that you started your comments by talking about the different levels of palliative care, because certainly when you think about the large numbers of hospitalists, primary care providers, frontline nurses, social workers, chaplains, most palliative care is not delivered by palliative care specialists. It's what we often refer to as primary palliative care. And yet our specialized palliative care teams are also increasingly in demand, particularly as people are dealing with the complexities that we addressed on the previous question. Palliative care teams are looked at as people who have a deeper understanding because of the nature of our work and how to respond in those circumstances. So we're looked at not only for the clinical support we provide to the patients and families, but also to the morale support, thank you for that, MC, that we're able to provide to the frontline staff and caregivers. But in this setting, are we going to have the workforce to meet the needs? And so we're having to be very creative in how we assure that the necessary services of palliative care, be they provided by the frontline staff at the so-called primary palliative care level or by consultants or specialists. Number of ways we can do that. I think many of our teams are finding they can expand their breadth, perhaps at the cost of depth, but expand their breadth by doing an increased number of what are often called curbside consults. So if a hospitalist has a case that they need some support on and they call me as a palliative care physician, perhaps we spend 10 minutes on the telephone or 10 minutes sitting 6 feet apart from one another at the nurse's station and have a conversation. And at the end they say, I think I got what I need. I can go ahead and address these needs and you don't need to do a formal consult. I think another layer of that would be what are often called one-offs, where I might do the formal consult, but perhaps not do as many follow-up visits as I otherwise might. And just a quick throwback to our previous question, I did find doing inpatient rounds over the weekend that I did a lot of my consults from the doorway. And I really appreciated, Moyo, on your comments in the first question. I acknowledged it. I talked to the patients and said, I'd love to come over there and shake your hand, but because of this whole virus situation, I need to keep my distance. Every single one of them understood it. They know what's going on. But just naming it and acknowledging it had, I think, a positive relational effect. So, I'm doing a slightly different model and perhaps delivering my care from a little greater distance and maybe not following up in the same way I would under normal circumstances, but it helps expand the reach of our team if I'm able to innovatively do that. Saturday, I had a family meeting with 3 sons from around the country on the Zoom video platform. The nurse I was working with Saturday set everything up, connected with the family members, and at 3 o'clock, we all 5, the nurse, myself, 2 sons locally, 1 son in Alaska, all got on a video conference and for 30 minutes had a very engaged and in-depth interaction. And at the end, the nurse and I, Beth, and I felt like we had really delivered high-quality palliative care services to this family, and the family felt so supported and felt like this was exactly what they needed. And they acknowledged, we realized, Doc, that we can't come in. We get it. We know this is tough for Mom, but hey, we don't want to be the vectors of that virus. They use the word vectors, but you know what I mean. And then finally, in the clinic setting Monday, I did a bunch of telephone visits, and I think of the last one of the day in particular, where this is a woman I'd never met. She's in her 70s. She has advanced pulmonary disease. And in the conversation, doctor, I need to know about the drugs you're going to give me at the end of life. Are you talking about managing complex symptoms as you're actively dying, or are you asking me about Washington's Death with Dignity Act? Both. I want you to tell me about both. Well, we ended up having a very rich conversation. Remarkable that somebody I'd never met on a telephone call, she had me on speakerphone with her partner in the room with her, and we went as deep as we needed to and as I probably would have if we'd been in the exam room together. And so these are all ways we can extend our services and reach out to people in times of need without necessarily doing things the way we've historically done it. And it's working out better than I would have expected. And then finally, on the Supportive Care Coalition's website, amongst other things, are resources like the Vital Talk tool on communication in the setting of COVID. And there's a variety of other communication resources of that sort out there, the CAPC webpage and others, the California State University Shiley Institute for Palliative Care. There are a number of different places that have an excellent array of resources that not only help our specialist palliative care teams, but that we can share with our primary care colleagues, our hospitalist colleagues, our critical care colleagues, our outpatient oncologists, cardiologists, if they're interested, in a variety of different ways to help people sort of deliver the services patients need. And with that, Denise, I'll toss back to you for MC and Brian.
Thank you. Yeah, MC and Brian, I would love to hear the ethicist perspective on this workforce issue.
You know, I think, sorry, Brian, I'm just assuming I'm going to.
You're faster than me.
You know what? I'm one of 9 kids. You learn as soon as you learn. So, kids being used very liberally here. One of the things that struck me, again, is that this is all about kind of competing calls to our duty, right? Everybody knows 2 things about what we have to do as clinicians. And right now I'm putting my RN hat on for a minute, my critical care background. When there's an emergency of any type, and this is an emergency on steroids, as we all know, it's all shoulders to the wheel. And, you know, you do what you can capably and with some degree of credibility, and also are licensed to do, certainly in a setting like a hospital or a clinic or something official. So there's that. And the other thing that we know is that, you know, the whole medical education model, which goes as well to nursing and respiratory therapy and every other part of the healthcare workforce professionally, you see when you do when you teach one. So you can be retooled pretty quickly to fill in some of these gaps in some instances. You know, I was in a meeting again on triage protocols the other day, and one of the dermatologists who was there was saying, I really wouldn't want to see me sent to the ICU to relearn what I can do to help. You know, I'd be less helpful than a Candy Stripe volunteer in that setting these days. So there's reality check as well. But one of the things that is really interesting to me is that we're not being asked as palliative care specialists necessarily to work harder. We're being asked to work smarter. And that might be because of fewer numbers. It's also because of some of the constrictions and restrictions that were outlined in question 1. But most importantly, I think what we're all learning is that there are techniques and devices like what we're doing here today that we would have seen as counterintuitive in the personal and intimate way in which palliative care is done, the way in which these extraordinarily important and sensitive conversations must be conducted. And we've learned 2 things, I think all of us who have now for several weeks been only meeting over a video conference or a telephone call. We've learned that in some ways, it's more efficient. And I don't mean so, you know, get in there, get it done and get out. I mean that it's more focused. We are spared the distractions of the side conversations with somebody else in the room or watching what's going on in the corridor or following the monitors or whatever. And so we get to the point. It's extremely intimate and personal, even this way. I made the comment to those of us who are on this call before, on this panel before we started, we're going to have to relearn how to have conversations in 3D because we have quickly adapted to using this. And I can stare you right in the eye in the same way that I did when you were physically present before me. So I really appreciated both Wiwa and Greg showing us how this can be done, and more importantly, that it's being done. We can kind of look at what seems counterintuitive and seems like the cheap way out and seems like ineffective and seems like so impersonal, and see that it's intensely personal. You can cover the same territory, etc. The availability of specialty care services, I think, has never been more important. And it's, interestingly enough, publicly acknowledged. You are referred to this morning's article in the Wall Street Journal. They're every single day in the Wall Street Journal, in the New York Times, in the Boston Globe, which is the paper where I am. Every single day there are letters to the editor, there are opinion and op-ed pieces about the need for people who are good at having these conversations and doing them under duress and in time-sensitive situations. So, the workforce issue continues to be incredibly important. I think for those settings and places where people are being asked to kind of take off the palliative care hat, the response is, I'm happy to put any other hat on my head, but I can't take that one off. We'll need it when you least expect it. And I think that answer is not only received well, it's expected. Thanks, Brian.
The other thing I would say about this particular topic is that although we're talking about a clinical situation in this particular question, I think it has broader implications. As most of us have seen in the papers in the past couple of days, that some of the major Catholic health systems have already reported having to furlough some of their employees. There's a lot of shifting going on, not only in a particular clinical specialty, but there's a lot of shifting going on in terms of the system-wide and the larger viewpoint as well. So, I mean, when we start to look at how we're going to shift and how we're going to redeploy resources, some of that's going to require creativity. It's going to require some flexibility. But we come back to one of the values that we have as Catholic healthcare systems, which is really this idea of solidarity as well. So we want to be with our patients. We want to be with our employees. We want to understand how we're shifting things in the short term towards utilitarian goals, but ultimately we want to see how any of these changes will best serve our patients, and we have to be prepared right now for an awful lot of change as we move forward.
Thank you, all four of you, and I just want to let you know we're getting comments from our participants who are solo clinicians, and they are very, very grateful for your responses, helping them navigate this difficult situation. Brian and MC, stay put right where you are, and we're going to move on to, this will be the last question I believe we will get to today. And we are starting with you both because this question falls under lots of umbrellas, but potentially this idea of human dignity and specifically the Catholic view of human dignity. So our first two questions have been more focused on kind of caregiver workforce, the clinician perspective. This is a very patient-focused question, noticing that caring for an immigrant or refugee population, people are picking up on some implicit bias amongst their colleagues. Also picking up on comments that might sound ageist or be reflective of ageism. And so we're going to start with you two and then go to our physicians next. How can you comment about this issue that is emerging right now?
Yeah, I mean, this is a fascinating time that we're living in because, all of us who had medical ethics in our clinical training, or we went to ethics school like Brian and I and many of the folks on the call, we did the lifeboat exercises. I mean,
yeah.
Had those as icebreakers. Now they seem particularly callous and cynical icebreakers for some group meetings, right? Because now they're real and we're implementing them. So this is what I would say. And referring back to one of my earlier comments, I think it's important to wrap triage and scarce resource allocation protocols in this kind of preamble or introductory piece, because healthcare generally has operated on a justice system and kind of randomly, first come, first serve. You're in front of me, I will do what you need and what would benefit you most. When we get to scarce resources, what we're really doing, and I referred to this in our earlier meeting last week, we're trying to balance what's a benefit, kind of the benefit burden ratio for this individual who's in front of me. Typically and traditionally, that was our ethical analysis. Now we're being asked to look at that and set it in the context of, in our society, given that we only have these scarce resources, where is the benefit there as well? looking at the healthcare professional taking care of these folks, for example, in the idea of limited testing or limited intervention. But also when there's, the healthcare person is out of the equation. And quite frankly, as I'm working with groups as they do these triage and scarce resource allocation protocols, they're never out of the equation because we're in a healthcare crisis. And so right away, there's a value assigned to protecting those who can help this crisis. So you see the leap from the individual patient to the societal good right there. But one of the things that's really helpful is to articulate these principles, and in doing so, putting those in the kind of juxtaposed with what we know has always been the tried and true, at least in modern medicine, method of allocating resources, which is physiological scale, scoring systems, et cetera. We will per se hear age mentioned. It's a given. With the comorbidities that our oldest and individuals in our population have, it will come up. That's not discriminatory per se. With regard to the other bases for discrimination, gender, refugee status or immigrant status, ethnicity, place of national origin, sexual orientation or preference, none of that figures into any model I've ever seen. That it figures into people's thinking is probably inevitable. They're human. The moment it figures into the arguments or the discussions even about how to apply these triage protocols and these scarce allocation of scarce resource protocols, the minute that we hear it, it's to be called out, it's to be addressed, and it's to be excised from the arguments, from the discussion. And if, quite frankly, if the person who is making those comments feels it so strongly, I think we all just mentally classify that person as an outlier. But I think it has to be specifically addressed. That's part of our duty too, is to call out something and say why we are calling it out. Brian, can I just, before my day job is calling me, and so I'm going to disappear from your screen, and it's intentional, but I'm really sorry about this. Thanks.
Thank you so much, MC. We appreciate you being here.
The first thing I would say is, let's be blunt. It's unjust to discriminate against patients or offer them resources based upon either age or immigration status or disabilities. And I think MC put it very well. In order to be transparent and just, and especially in order to continue our mission to the poor and underserved and the vulnerable, it's important to be conscious of how we're making allocation resource decisions, which ought to be on clear clinical criteria. So a number of states are adopting, SOFA or modified SOFA. While there are some difficulties with those clinical scoring systems, they're the best we have right now, and at least to provide some consistency with regard to how we approach these kinds of issues. And I think it's also important to step back a little bit, and although we're doing immediate triage, we also have to keep in mind that the vulnerable among us may not be the first ones to access healthcare resources. And so we have to sort of think in the future about how we're going to use resources as well to support those vulnerable communities.
Excellent points, Brian. And I would invite Greg and Muiwa to chime in on this too.
Greg, do you mind if I just go on?
Please do.
I think I go back to one of the things MC had brought up last week in terms of the conversations when we started this. And there were two questions. She said, what is my duty and to whom is that duty owed? And these should serve as guidelines for us in terms of what we're doing here. This is the Supportive Care Coalition. We're talking of Catholic healthcare systems that are providing care right now. And I think one of the things that attracts a lot of us to Catholic healthcare systems is the mission, the vision, and the values that these Catholic healthcare systems have and hold. As Brian just mentioned, the fact that this comes up is unjust. And, within the Catholic social framework, human dignity or life and dignity of the human person is key. Again, this is something that was highlighted last week. And we're caring for God's creation here. And I think with everything going on, as part of what we're looking at, one of the things that I think strikes me is if we realize that we have such populations, in a time like this, if we could reach out, as Brian said, sometimes people in vulnerable populations do not seek care immediately. And maybe this is a time to find someone who can reach out to a spokesperson in those communities right now to find out what is going on, what is the thought in those communities, and provide information. A lot of people are getting information from Facebook, sources that are not credible. There's a lot of things going on out there that people are hearing. I'm hearing things about people drinking Lysol because they hear that click, kills the virus. This kind of things pass down among vulnerable populations and can cause complications, not related to the disease itself, but in trying to prevent the disease. And so I think if possible, some sort of public awareness in our various locales. I know this is a difficult time, and I'm just putting this out there because I think it might be something to consider, would be ideal. And I'll let Greg take it from here.
Thank you, Moyowa. As a physician ethicist, one of the things I really valued during my training was the Aristotle notion of phronesis, or practical wisdom. That is, how do we take ethical principles and use our lived experience and the reality of the situation we're in and apply them as soundly and as justly as possible? And so when I think about a lot of discussions around rationing, I'm really struck by the article that Randy Curtis and colleagues published this past weekend. The title is The Importance of Addressing Advanced Care Planning and Decisions About Do Not Resuscitate Orders During Novel Coronavirus 2019. One of the things they got at is before we get into in-depth discussions of rationing, we need to think about the prior conversations that are more individually focused on what do patients and their families truly want. And Moyowa highlighted this last week during our call very nicely. And so in a practical application, I was on a phone call with the hospitalist team from one of our smaller hospitals, average daily census around 50. And I know for some people in rural settings, that's not a small hospital, but the hospitalists there, I loved where they went with it. They started saying, how can we reach out to nursing homes and talk to their medical directors and their director of nursing services to talk about ways where we could have these conversations more clearly outlined, make it where the people who want to go through the emergency department transfer and potential invasive life-sustaining therapies get their preferences met, or at least get put on the list for it, but that those who don't want that are identified, acknowledged, and have the proper advanced directives, PULST forms, MULST forms, etc., completed. Again, starting with the patient and what they do and don't want, and looking at it that way. So we're really looking at ethical principles such as autonomy, self-determination, as well as beneficence prior to getting into the rationing decisions. And then that's going to change the denominator, presumably, because if we really do these conversations well, there are going to be a fair number of people who otherwise might have ended up in our emergency departments or our hospitals, where emergency physicians, hospitalists, and critical care docs are having to make kind of in the midst of an event decisions around these life-sustaining interventions, as opposed to being able to honor advanced directives or advanced care planning that have been carried out a little further upstream. And so one of the other things that came up is the JERIPEL podcast that Alex Smith and Eric Wadera out of UCSF do every, I don't know how often, but they recently had a podcast specifically on this topic where they had a couple of experts who have developed resource allocation materials historically going back to the H1N1 pandemic. and really looked at the different ethical criteria by which we operate. And I think MC and Brian really hit on it. If all we're using is age because of age, then that's discriminatory. If you're using age, 85 and above as a specific mortality or morbidity risk indicator using tools like the MSOFA or SOFA clinical risk scoring assessment, and you're combining it with multiple other things in a little bit more of an evidence-based manner, perhaps it is appropriate to take into account. But it ought to be done patient by patient as opposed to in a sort of blanket, we will make all of our COVID positive patients DNR or things of that sort. Certainly there are institutions considering that. One thing that we found in Providence is we do have 51 hospitals. Happily, none of them, to my knowledge, are currently on crisis standards of care, so they can still take this more upstream approach. And with that, Denise, I'll toss back to you, and I realize that the time is getting shorter than I noticed, so thank you very much.
Thank you, Greg. Thank you, Muiwa, and thank you, Brian, for such rich and nuanced responses to these questions. And as we anticipated, we are at a moment when we would normally take a few live questions from all of you by navigating over to the question panel. I invite you to go ahead and do that, knowing that we will take these questions and queue them up first on our follow-up part 3 to this webinar that will take place on April 16th. In the meantime, for those of you who have been using the chat and questions panel throughout the webinar, I want to highlight that we have been replying in that chat panel by posting all of the resources that have been mentioned by our panelists today. So that is where you will find the link to the Wall Street Journal article that just came out this morning on how needed palliative care clinicians are right now. That is where you will find the links to SCC's COVID-19 page, our caregiver well-being page. That is where you will also see the link to the code status and COVID patient document that was started by Curtis et al. And adapted by the Supportive Care Coalition and the Catholic Health Association. And we also just posted the link to, I'm pretty sure, the Jerry Powell episode that you all were mentioning that discusses resource allocation. So all of that is right now available in that question and chat panel if you want to grab it before we close down the webinar. Lastly, and Brian did not mention this, but yesterday, Brian and colleagues from Catholic Healthcare, ethicist colleagues from Catholic Healthcare, did an hour-long webinar on the specific ethical issues arising in the midst of the COVID pandemic. And so I do know that that recording will be available soon.
Yes,
I believe
hopefully tomorrow.
Today. Hopefully tomorrow. Okay, great.
Yeah.
So keep
Maybe
an eye
today,
out for that. As soon
but
as
it should be by tomorrow.
Okay, wonderful, wonderful. As soon as it is available, we also will add it to the SCC website. In addition, I want to remind everyone that next Thursday, same time, again, as part of this 5-part webinar series on COVID, we will be welcoming physician and bioethicist Dan Silmacy. He will be taking a deep dive into the epidemiology of COVID and also from that, the ethical responses and issues that are arising in the midst of COVID. So we invite you for the 9th and the 16th, and then just looking forward to the Thursday after that, we will be having a webinar focused on the social work and chaplain perspectives, how to provide social work and chaplaincy care in the midst of these unique circumstances. And that, again, will be a panel of a chaplain, a palliative care chaplain, palliative care social worker, and mission leaders from the Catholic Health Association. So we also, registration will be, I believe, is live for all 3 of those future events, and we invite you to register and join us then. Everyone who joined us today, I do thank you so much for taking the time. The recording for this webinar will be available tomorrow. As we end this webinar, a survey will come up, and we really ask your kindness in completing that survey for us. Again, add questions that you didn't get to ask today. We read those carefully and use those to plan what we will do next. Thank you, everyone. Stay safe, stay healthy, stay home, and we will see you again next week.
Thank you, Denise.
Thank you, Denise.
Thank you, Greg and Luan, Brian.